Can we all see that okay? So if everyone can see that okay, I just need to shuffle a couple things around my screen because of course that's how this stuff goes. All right, I've got a good thumbs up. Excellent. So today we're going to talk about first of all, using first-person language in integrated care and some of the ethical implications for doing so. Objectives, they relate back to the broader program objectives. One of the broad program objectives is to integrate relevant social determinants of health into the evaluation of patients and communities, including physical, mental, and emotional aspects of health and wellness, with the consideration to relevant cultural, socioeconomic, and structural factors. So the objectives for today are really getting to some of those relevant cultural, socio-political and structural factors, specifically related to our choice of language and stigma and how that can create barriers to care. Language very much matters. And I know that we've talked about this before, and I guess I would refer back to Dr. Torum's presentation from October, where he talked about perception. And this is more about how the clinician's perception can be influenced, less than how clinicians are impacting patients' perceptions, but it is very much related, I feel like, hopefully complementary to the presentation that he gave. So before getting into it too deep, we are going to kind of have a little bit of interaction. So I want you to consider a scenario. The CDC anticipates that there's going to be an outbreak of zombies. It's going to be in an Ohio village, and I found this Ohio village, which the population back in 2010 was 606 individuals. So if zombies hit Rising Sun, Ohio, 600 people are going to die. Now we have a couple programs to possibly find solutions through. So in program A, 200 people in the town will be saved. But if we choose program B, there is a 1/3 probability that 600 people will be saved and 2/3 probability that nobody will be saved. So which program would you choose? I'll give you a minute to vote on program A or program B. And Jamie, I assume that you'll know when everybody's voted so that we can go on to the next one.
It doesn't seem.
I am unable to vote.
Doesn't seem to allow people to select an answer. So if people can just use the chat box for.
Well, that is frustrating. Okay.
Especially given all the things we did ahead of time.
We tried real hard to get this to work. Yeah, if everybody could just put into the chat box, you know, which would you select, program A or program B? So A, again, 200 people will be saved versus, you know, some probabilities. You either a 1/3 probability save 600 or 2/3 of probability you save nobody. All right, so when I look at the chat, it looks like we've got some A's, we've got some B's. Jamie or Sandy, if you could help me out while we go to the next slide and just try to tabulate the number of A's and B's, that would be amazing. So we have two other alternatives. We also have program C, where 400 people will die, or program D, where a 1/3 probability no one dies, and 2/3 probability that 600 people die. And if the poll works, then that's great. And if the poll doesn't work, go ahead and throw it into the chat. Oh, the poll's working this time. That's good. All right, excellent. Whew. All right, so it looks like almost everyone has voted. I'm not going to, so I don't know if we can end it here maybe. So most people picked program D. Some people still pick program C. Does anybody want to share if they changed their response? Or did everybody pick the same choice that they did? Did you what was the variation between the two choices, and what made up your mind? Quiet group today. All right.
Nicole, weren't there 4 choices?
Yes, there were 4 choices. So which 2 did you choose?
Oh, which ones did I choose? I think I chose B and C.
Okay. Anybody else want to volunteer their responses?
I chose B and D, and I thought they were pretty much the same thing.
So this is why I was hoping that the polls would work, so we could look at the percentage of, which got which, because that is very true. Programs A and C are completely identical, and B and D are completely identical. And what's going on here is we're just shifting the wording. We're shifting the focus from risk aversion to risk taking. So in the first scenario, the description is in lives saved. In the second scenario, it's descriptions in lives lost. So when we're doing that, we're switching, our focus, and our choices are very much influenced by the way options are framed through the emphasis on different wording, different reference points, and different emphasis. The most common framing, and all of this is because of the framing effect. So actually, there we go. The most common framing draws our attention to either a positive gain or a negative loss associated with options. We're susceptible to this sort of framing because we tend to avoid loss, which is why we tend to find it more attractive when things are presented in a positive light or positive aspects are highlighted rather than negative ones. So the study, which I renamed to Zombies, but was actually about what they called the Mojave flu in the original study, was done by 2 Israeli psychologists, Amos Tversky, I'm probably butchering that, and Daniel Kahneman, again, probably butchering, but they systematically studied and proved the effects of framing effects influence on our decision making back in 1979. And they call this prospect theory. So they have, so this study was published in the Framing of Decisions in Psychology of Choice. And you see this framing effect as one of the multiple cognitive biases that we're susceptible to. So the framing effect comprises a set of concepts and theoretical perspectives on how individuals, groups, societies organize, perceive, and communicate about reality. Framing involves a social construction. So through mass media sources, social media, political or social movements, political leaders, anything out there that we're interacting with in society can help frame our beliefs about things and beliefs about how reality really is constructed. So equivalent information through the framing effect can be made to look more or be perceived as more or less attractive depending on what's highlighted. Our brain tends to use shortcuts. So very often we tend to favor information that's easily understood and recalled rather than things that are more complicated. We rely heavily on an emotional state during our decision making. So if you think about what the emotional state was in when you were listening to a particular person give a speech, what was their emotional state? Were they kind of doom and gloom or more positive? And you're going to feel differently about the information based on how you felt during that time. At an individual level, this impacts our individual choices. You see the difference between, as the example that I put on the slide, are you going to choose a yogurt that has 20% fat versus an 80% fat-free yogurt? Most people are going for the 80% fat-free, although it's the exact same thing. But at a system level, it can completely impact public opinion. So Frank Luntz is a good example of someone who used the framing effect to his advantage in politics. And he was the one who was responsible for reframing the term global warming to climate change. And that simple wording has gotten a whole bunch of different people to be on board with the concept, even though it's the same thing. So this impacts the care that we provide our patients. And this is why it's really important to understand the framing effect and other types of cognitive biases. Because when words are used as descriptors of one aspect of a person instead of to describe the totality of a person, we can either contribute to or reduce possible stigma. PersonFirst Language was first proposed in the wake of the Americans with Disabilities Act in 1990 as a strategy to define people as more than their illness or diagnosis disability. And it centers around the effort to define people first, and at the center of all of this, providing them with integrity and worth that they deserve based on the basis of their humanity, versus state-based language, which is so state-based is a person with symptoms, person first is the person with the illness or disorder, and then trait-based, which is that's labeling person as a schizophrenic, so describing the person as the thing. And person first just simply means identifying the person first as that humanizing factor to whatever then modifying illness or descriptor is. So trait-based language, that using terms like schizophrenic, addict, borderline, diabetic, epileptic, those are pre-modified nouns, and pre-modified nouns can be particularly problematic because of a concept in linguistic relativity known as the Sapir-Warf hypothesis. In short, it says that an individual's language directly influences the speaker's cognitive processes and the way they experience the world. So the use of pre-modified nouns changes what the speaker and ultimately the community, the patient, our colleagues believes about the people being discussed. Words that generated a positive or negative attitude then can perpetuate or reduce stigma. When we're perpetuating stigma, we also can be leading to a sense of internalized hopelessness for the patients. And I think what's important to note here is that what people call themselves is very different. There are many schools of thought in the recovery world, substance use recovery world, that, so AA being a good example of the term alcoholic being used. If a person chooses to self-label as an alcoholic, an addict, a whatever, that is completely within their rights to do so, but we need to be careful about what our language is, because a person self-identifying is very different than hearing your physician or your counselor call you this. So this is important because when we're using framing and we're not mindful of framing, we're using particular language that might increase stigma. It very much does impact stigma. So there's a study done, so this references a Slumsky article, and the study looked at the beliefs about people with substance use disorder, whether it was a brain disease versus a moral weakness. And it looked at the percentage of people who believed that, individuals had a genuine choice, regardless of also holding the belief that this is very much a biological disorder so believing it's a brain disease, but also thinking that there's a genuine choice involved. And when they surveyed resident physicians, 63% of them believed that there is a genuine choice, regardless of knowing any of the biology behind it. 44% of attorneys also believed the same thing. And the more control they thought a person had over the substance use or addiction, the more negatively they viewed that person. So the article quotes a couple of individuals, one of them being Jonathan Avery, who's the director of addiction psychiatry at Weill Cornell Medicine, and has done some research on reducing stigmatizing behavior amongst clinicians. And he was quoted as saying, the negative language we use to describe individuals who struggle with substance use disorders can perpetuate stigma of all these diseases and contribute to a culture that devalues the individuals. Nora Volkow from the National Institute on Drug Abuse also indicated that substance use disorders are currently the most stigmatized medical problem. The impact of stigma, and this is how we transition into some ethics, is that our actions very often follow our beliefs. So if we view individuals with psychosis or substance use disorder, or name your condition in a negative way, we're going to have a more stigmatized belief system, and we're going to do things that then impact that patient. So stigma can lead to exclusion of individuals from certain groups or activities. It can lead to discrimination, avoidance of those individuals, losing sight of their humanity. It can lead to differential treatment being offered, and sometimes even controlling or managing the activity for the person with the illness, believing that they're incapable because we've framed our language in such a way that leads us to do that. Knowing that stigma is a major obstacle care is one of obviously the major ethical considerations. If we need to get more people access to care, doing anything that we can to reduce stigma is an ethical obligation on our part. If only 10% of people aged 12 and older with the substance use disorder receive treatment, we have to start to look at why. And when we're using stigmatizing language and language that does not put a person first, it potentially could be leading to people feeling afraid to tell their physicians, counselors that they have a problem with a substance. It could lead to people being afraid to seek treatment for a particular illness, being afraid to share what's going on with them because they don't want to be, they don't want to be shamed. They might be embarrassed. They also might, feel like they too can start to internalize this concept of it being a moral failure rather than recognition that, there are just biological problems. So another study, Granello and Gorby, actually looked at practicing mental health counselors and counselors in training. One of the things that they found is that mental health counselors who hear the term schizophrenic are significantly more likely to believe that individuals with that diagnosis need to be controlled and disciplined. So it's not hard to imagine how this plays out in clinical practice. Counselors who use or hear their clients with schizophrenia referred to by the label end up making therapeutic choices that are influenced by that terminology. Changing our language means that we can engage in less stigma-based decision-making. So if we change our language to person with schizophrenia, person with substance use disorder, it allows for us to make a better, more humanistic assessment of the individual and what their capacities are. And we know that that could impact, if we're looking at them in a different way, then that's going to impact how we view what treatment options are available and what they're able to do on their own to be able to help themselves with their illness. So simply by switching or flipping our language to use a first person type of language preserves a client's dignity, can reduce stigma. Rather than using the pre-modified nouns, we need to switch to post-modified nouns so that we're doing things that are in a person first fashion, which will allow our planning and our decision making to be less authoritarian and restrictive. In summary, language matters. Across all of the helping professions, we all hold the same oath that, similar to the Hippocratic Oath, above all, do no harm. This ethical principle of non-maleficence, it is at the core of all of our ethical codes, and we need to be very mindful to be empowered, helping people empowered to do good, and changing our language minimizes the potential for harming and restricting our clients and putting more respect and dignity to the center of our practice. These are my references, and that is all. Any questions?